All right, well, thank you. I appreciate the opportunity for being here today. My name is Joshua Miller. Actually, if I'm going to be 100% honest, my name is actually Doyle Joshua Miller. The D is first. My parents, in an effort to confuse everyone and make every test I've ever taken just a little more challenging because they never get my name right on any kind of form I have to fill out, they had me go by my middle name. So my first name is Doyle, if you wonder what that D is for, but I go by Joshua. Today we're going to have a discussion about the effects of aging on the joints, the tendon, and bone. And I want you to know, I want this to be a little bit more informal. Certainly at the end we're going to have some time to ask questions, but I'd also like it if there is a pressing question. I know when I've sat in talks, sometimes I have a pressing question, and the likelihood of me remembering that question all the way to the end of the talk is pretty low. So if you have a pressing question, feel free to just raise your hand. I'll come on down and we'll get that question answered. That way things don't get forgotten. So with that, let's go ahead and get started. I want to introduce myself first. And first question most people ask is, where are you from? Unfortunately for me, that's a great question. As you can see on the map there, these are the places I've lived for prolonged periods of time, which means that no place has been too long. But I've lived all over the country. I've lived in the South, the East, the West, loved it, lived everywhere. But ultimately, as I was looking to settle down and stay in one place for a long time, we looked at the Northeast because it really is just a beautiful area, and the Tri-Cities here has really become a wonderful home for us. I've got a wife. Her name is Valerie. I've got 4 kids. In talking with my wife, I always get advice from her about things like this, on what she thinks would be interesting. And she said, well, you got to have some type of a cliffhanger. You got to have some reason for people to stay and watch. I got to be honest, we're talking about arthritis and aging. There's not much surprise here. So the only cliffhanger I could come up with is you got to stay to the end of the talk to see my beautiful wife and kids. So that'll be the cliffhanger. So I'm an orthopedic surgeon. I work with Northwest Orthopedics and Sports Medicine. Our office is, actually we have several offices, but one of our offices is right across the street from KADLEC. We've got another one off of 395 in Kennewick, and then another one more closer to the Columbia Center Mall in that area. 395 in Hillbrand. So across, it's in the KADLEC office building, clinic building there, right across from the Trios Hospital. So any of those 3 locations, I actually kind of bounce between a couple locations. Yeah, it's... So to let you know a bit about my education, I did my undergraduate at BYU. Hopefully there's some Cougar fans out there. I majored in microbiology and philosophy, and then minored in chemistry, mostly just because I was a glutton for punishment. I then went on to medical school at UCLA in Los Angeles, where I got my MD, and again, just couldn't get enough of school, so I decided to get my MBA as well, and did that there. After medical school, I did my orthopedic residency training at a place called the Campbell Clinic. Now, I know most of you are sitting there thinking, why would anyone move to Memphis, Tennessee? That is a great question. My wife kept asking me that. But the Campbell Clinic is actually one of the leaders in orthopedics. The leading textbook, called Campbell's Operative, which is the most widely used orthopedic textbook and is published in multiple languages around the world, is written by the staff at the Campbell Clinic. And because of that, and because it also has a long history of leadership, in fact, 8 of the past presidents of the American Academy of Orthopedic Surgeons, the biggest body of orthopedic surgeons, have come from the Campbell Clinic, including the founder of the American Academy of Orthopedic Surgeons, who is Dr. Campbell. So, because of all that, I wanted to bear the heat of Memphis and enjoy my time there, and so I went to the Campbell Clinic for my residency. After that, I did a sports fellowship at Washington University, not in Seattle, but in St. Louis. Again, it's one of the top hospitals in the country. And it provided me some unique opportunities. I got to be one of the team doctors for the St. Louis Rams, who got destroyed a couple times this year by the Seahawks. Yeah. And as well as the St. Louis Blues. So that gives you a little bit about my background, about my training, and where I came from. And, oh, I forgot. I've got all these fun little pictures of the places I went. So, The obvious question then is I'm an orthopedic surgeon. What is an orthopedic surgeon? Every once in a while I get confused for some other people. People come up and say, you're an orthopedic surgeon, so do you do braces or? That's an orthodontist. I specialize in muscles, bone, and joint problems. So basically, if you've got a problem with your muscles, your bones, or your joints, you want to see an orthopedic surgeon. They're the people that you go to. Some of the common problems I manage are broken or fractured bones. We'll talk about that a little later today. There's some fun things about that. But just as a side note, broken means the same thing as fracture. What you'll find is that in medicine, we like to use lots of words that mean the exact same thing. It's just a matter of making it, just a way of getting us all a little more confused. I also deal a lot with arthritis, muscle and tendon problems. A lot of you have heard of the rotator cuff. Ligament problems. Anybody who likes sports has definitely heard of the ACL, the dreaded ACL tear, and as well as cartilage problems. So those are all common things that I deal with. And as an orthopedic surgeon, we handle those problems. Now, to start with, as I'm going to go through this presentation today, we're going to talk about a handful of different problems that people can have. We're also going to talk about different ways to treat those problems. And I think in understanding treatment, it's important to understand my personal philosophy of how I go about treatment, because it does temper how I present the information today, and I think it's fair to you that you all know that. So first of all, I am an orthopedic surgeon, and so most people hear the word surgery and think all I do is spend my time in the operating room, and I don't. I spend a lot of time in clinic, and in fact, my personal belief is that surgery is typically, in most cases, the last option. That we start conservative. You start with the easy things that don't require seeing me in a pair of scrubs and a mask. But we start with the conservative management first. Start with the things that we can do that don't require a lot of risk, and slowly work ourselves, if we need to the more aggressive treatments. And that way, when we get to the more aggressive treatments that obviously carry more risk, you've tried all the easy things first. So, to me, surgery is not the only option. It's not in most cases, and certainly it's rarely the first. Also, when you're working with people, and one thing I've learned in medicine is that really it is a team effort. Ultimately, you spend a few minutes with me, and we talk about options, we talk about a plan, but ultimately you're going to leave, and you're going to do whatever you want to do. And so me telling you, hey, you have to do A, B, and C doesn't make a lot of sense. Because if you don't want to do it, you're not going to do it. So really for me, what I've found to be most effective as I work work together with my patients is working to sit down and come up with realistic plans for them. Working as a team to figure out how we can help them to get back to what their goals are, to doing what they want to do, and to talk about what realistic expectations are. And it really is a team effort. Like I said, a doctor can tell you something, but at the end of the day, you get to walk out and do whatever you want to do. So let's go on to talking about aging and the effects of aging. Today we're going to cover the three things. We're going to cover the joints and predominantly talk about osteoarthritis, what that is, the different causes, and what we can do about it. We're going to talk about the tendons, particularly tendinitis, tendon tears. You hear a lot of those things and what all that means. And then we're going to talk about the bone. And we're going to talk about common fractures that we often see as we get older, things we become more at risk for, and the impact of those fractures. But before we delve into that, it's important that we do a quick lesson in anatomy. So as we talk today, you understand a little bit better specifically what we're referring to as we talked about different orthopedic things. So first of all, we have bone. Bone is a living organism. It's amazing. It is absolutely amazing. It can withstand a great deal of stress, impact. Bone is constantly resorbing and regrowing. And so as we talk about that, it impacts what happens. And as we get older, that changes a little bit. Then we can talk about articular cartilage. Like I said, we like to use lots of words that mean the exact same thing. Articular essentially means the joint. It's the area, the cartilage is the area of the joint that covers the bone. And so, as we talk about cartilage, cartilage is a durable, flexible tissue that basically helps to absorb a lot of the stress that the bone would see. It helps to cushion the joint and helps to make a nice smooth surface. In between that joint, often you have another tissue that can be called cartilage. It's called the meniscus. Let's see if we can go there. There we go. So the meniscus in the knees, but it's usually in joints that bend, that you'll see these meniscus. And this is a thick, kind of more rubbery tissue that, again, helps to pad and helps to increase the surface area so that the stress is more distributed. The labrum is what we see in joints that rotate. And a labrum is, again, a thick cartilage tissue. It feels like rubber that comes around the lining of the joint and helps to increase the surface area and helps to provide a cushion. And so as we go through these things, we're going to be talking about some of these things. And you'll definitely, if you go talk to your doctor, you'll often hear them use these words like labrum or meniscus or the cartilage. And we'll talk about all that, what that means. Then there's two more important things to know about. One is called the ligaments. Now, ligaments connect bone to bone. So, ACL, anterior cruciate ligament, connects the femur or thigh bone to the tibia, the leg bone. So if you're talking about something that connects a bone to a bone, it will be a ligament. A tendon connects the muscle to the bone. So whenever you have muscle, you'll always, as you go down that muscle, what you'll find is that tissue will start to go from that red, beefy looking thing to a more white, silky looking tissue. And that's the tendon. And the tendon then will attach to the bone. Finally, you have the muscle. That's the area that contracts. That's the beefy muscle, meat part. And that area contracts. And the muscle, the whole purpose of muscle is to move joints. So the muscle helps to move the joints. So now that we've done a little bit of anatomy, we've done our gross anatomy class for today, let's dive in. So first of all, let's talk about the joints. And as we start to age, one of the things a lot of us have felt before is when you wake up in the morning, you probably feel it more than ever, is you may feel restricted, stiff. You lose some of that flexibility. And a lot of that happens because the water content within a lot of these tissues, within the ligaments and the tendons, changes. It decreases. So that tissue becomes less flexible, less pliable, and less resistant to stress. Also, the articular cartilage thickness can decrease. And as we talk about arthritis here in a moment, I'm going to constantly refer back to this tire analogy. So I want each of you, as we're talking about it, to think about a tire. And this tire has some nice thick tread on it. It's a brand new tire, nice thick tread. So what is arthritis? What is it? Somebody at the beginning here had asked me, what is the definition of arthritis? Well, let's first look at the word, osteoarthritis. It comes from three words, Greek words, osteo, meaning bone, arthro, meaning joint, itis, inflammation. So it's basically bone joint inflammation. And that's exactly what it is. It's a chronic progressive disorder in the joints that's caused by the loss of the cartilage. Now, the cartilage, as we talked about, does what? It helps to cushion the bone underneath that cartilage that's in that joint. So as the cartilage gets thinner, the bone sees more stress. It sees more of that force and that pounding. And so it gets irritated. What happens when we see stress? We get irritated. Our bone does the same thing. Our bone gets irritated and gets inflamed and angry, and it causes pain. So as we talk about things, what we often see is we see narrowing of the joint space because the joint space where that cartilage is thins. If you're wondering in your head, I can't really picture cartilage, what I want you to think about is the last time you had a chicken leg and a drumstick. And at the end of that drumstick, there was that white curvy part, the white glistening smooth substance on the end of that bone. That's cartilage. And our bones have the same thing, that white smooth stuff. In fact, it is so slick. This is what's so cool to me. Our bodies are amazing. That cartilage in our knees is so smooth that the friction between the two edges of cartilage in our knees is less than the friction you would have if you put two pieces of ice and rubbed them together. Pretty amazing, huh? That's our bodies. It's absolutely amazing to me. So again, what happens is as that bone gets stressed and irritated, as that bone, because the cartilage is thinner, the bone gets stressed, it gets angry, and gets thinned, what happens? It forms new bone. It's just like us. When we get stressed, we get irritated, we get upset. What do? We try to get other people to help us. And basically, that's what the bone does. It basically stimulates new bone growth. And that's why you get, on arthritis, you'll often get areas of little bone growth or bone spurs. Orthopedic surgeons call them osteophytes. Commonly, they're referred to as bone spurs. And so they're little pieces of bone. Now, those aren't typically the cause of the pain. They're typically a sign of the pain, the sign that the cartilage is wearing out. So, and then also as you talk, you'll also often see arthritis referred to as degenerative joint disease. Again, essentially the same thing, just another term. It's same, just another way to say the same problem. So, arthritis is, as most people know, is a big problem, especially as we get older. It is very common. Estimated that over 27 million Americans suffer from arthritis, that nearly 1 in 2 people before the age of 85 will get arthritis in their knees, and 1 in 4 will get it in their hips. So it's a common problem that people face. So what causes arthritis? That's a great question. If one of you guys can find the answer to that, we can win the Nobel Prize. It is a great question. Now, the problem is that we don't know exactly what causes it, but we know a lot of things that are correlated with it or associated with it or seem to speed it up. Just now we're going to go to that tire analogy that we talked about. So you've got this nice thick tread on the tire. And when you get a new tire, it's great. But what happens as you drive that tire? That tread starts to narrow. It starts to get thin. Similarly, as we age, in some people, that cartilage starts to thin. They start to get arthritis. Now, some of the things they've found that can increase, that can make it go faster. Now, when I say it's associated, we'll take a quick second here. Talk about the difference between causation and association or correlation. I had a car, and for some reason, I have no idea why, my tire would randomly go flat. I would walk out to my car, and it would just be flat. And this happened about a dozen times. Drove me crazy, because if I pumped it up with air, it would be fine again. And I would bring it into the tire store, and they would look at me like I was crazy, because I would say, my tire went flat. And they look at it and say, it looks fine now. And I'd say, you're right. So I kept having this happen. And every time it went flat, I have to get out, I have to get my jack up, and inevitably, I would get my pants dirty. And so my wife got to know every time my tire went flat, because I'd come in with filthy pants. And ironically, every single time my tire went flat, I was wearing these light tan pants. Couldn't be wearing the black ones. Always the light tan pants. My wife pointed out, she said, every time you wear the pants, and then jokingly she said, maybe it's the pants that are causing the flat tire. That's a correlation or association. It's not causal. Obviously, the pants weren't causing the flat tire, but it can correlate. Now, whether that correlation is important, we don't always know. We think these are important in arthritis development, but it may be that someday we learn that they weren't nearly as important, that there were other things that just made it look that way. Could be that I just wear those pants on the wrong days. So one of those things is obesity. Obesity, particularly in the knee joint, has a strong correlation of increasing that wear. Going back to the tire analogy, if you put a lot of weight in that car, the tread on the tires seems to wear faster. Genetics. There's probably a predisposition, particularly in the wrists and the hands. People that have a genetic predisposition for arthritis, their parents have had arthritis, their grandparents, often that may be a good sign that they may develop it too. Although that doesn't hold 100% of the time. Again, more common in the hand and the wrist. Again, going back to the tire analogy, it would be kind of like saying, the substance of the tire, what that tire is made up of. Some tires just last longer than others. Trauma. If you injure your knee, if you have a bad injury to the cartilage, that can often lead to arthritis. Again, a high correlation. Instability. Again, if the tire is wobbly on that car, what happens? Wears away faster. Same thing we see here in the knee is that people that have a lot of instability in their knee have a higher tendency to develop arthritis as well. And finally, age. Frequency of arthritis increases with age. So my wife, like I said, I always get her advice. I was practicing this with her, and she said, so does everybody get arthritis? And the answer is no. Arthritis isn't inevitable. There are people that are 100 years old that have joints that look pristine. No joint space narrowing, no arthritis at all. So like I said, we don't know why it happens. We know things that are correlated, but hopefully someday we can figure out why. Yeah, bad luck. So what are some of the symptoms? I almost felt like this slide was probably unnecessary because I think most of us know what the symptoms are. Either we've felt them or someone we know and love has felt them. Basically, it's stiffness, swelling in the joint. It often occurs with bending. You have what's often called startup pain, or pain in the beginning of the morning, or when you get up from sitting for a long period of time. All those things can cause arthritis pain. Vigorous activity. If you go do a long walk the next day, your knees are just achy and sore and swollen. You can have some locking, some snapping, some clicking, what we, again, another phrase that everybody else, most people call it snapping, cracking, and popping, or Rice Krispies. We call that crepitus. So you can have some crepitus. And then you've got pain. You may occasionally have some weakness and buckling in the knee. A lot of people can actually predict the weather better than the weatherman. They can say, no, it's going to rain tomorrow because of the pain in their knees. But really, probably the most common question I get when I see people in clinic, they say, man, this is killing me. This really hurts. It can't be arthritis. It hurts too much. Actually, arthritis hurts a lot. Arthritis is extremely debilitating. And as you feel that pain, yes, it is arthritis, and yes, it does hurt that much. So how do we diagnose arthritis? If you're wondering, man, do I have arthritis? First thing is a physical exam. An orthopedic surgeon or your primary care doctor can do a physical exam. They can look for specific things and rule out some other things that it could be. But ultimately, x-rays, particularly weight-bearing x-rays, can be particularly helpful, particularly in the hip and the knee. So as you look, what happens is x-ray shows two things really well. It shows bone and it shows space. It doesn't show us the cartilage, but what it does show us is the space where that cartilage should be. So we got we've got a shoulder joint, we've got a hip joint, we've got a knee joint, and you can see the space, that black area, your knee's not floating in the air. What we're not seeing is the cartilage. And so the cartilage, as it wears away, you get the dreaded, as everybody's heard, the bone on bone. And so right here, we got the bone on bone. And really what it is the cartilage is worn away. And now it really is what we call subchondral, or the bone that's just below the cartilage, bone rubbing on another bone. And that can become very painful and irritating. So what do we do about it? Once we've diagnosed, we know we have arthritis. Well, like I said, my philosophy is start conservative. Let's start at step one in conservative management. There's really a handful of important things that we can do there. First of all is lifestyle modification. So decrease high impact activities. The running, the jumping, the pivoting, the climbing, all of those things can be really hard on the knees. Even walking can be more high impact. So as you're looking at what exercises to do, because that's the other side of the equation, you've got to stay active, you've got to exercise, because if you don't, that also causes problems and can increase your likelihood of arthritis. But as you're looking at the exercises, look to do things that are low impact. Water aerobics is my favorite. I love water. Every motion you make is resistance, and yet there's very little impact. Biking can also be a great one. And again, you've got the elliptical. There we go. Elliptical. We're doing charades now if you haven't followed me. So elliptical can also be extremely good for people because, again, you're not having the impact on your hips and your knees with those kind of motions. Exercise, like I said, is important. One study showed that among adults with knee arthritis, engaging in a moderate physical activity 3 times a week can reduce arthritis-related disability by 47%, by almost half. So that's really important that we stay active, we stay healthy, and we're exercising. Weight loss is another huge part of lifestyle modification. Another study showed that a loss of just 11 pounds can decrease the chance of osteoarthritis in the knees by 50% in women. That's huge. And in fact, there are several other studies that have shown that those people that are preparing for, that are considering a knee replacement, if they can lose as little as 10% of their body weight. So if you weigh 200 pounds, just 20 pounds, you can significantly decrease your risk of needing a knee replacement right away. You can postpone it for a significant amount of time because the pain improves. So weight loss should always be a part of the initial treatment. Now, I know weight loss is hard. It is a Like arthritis, it's multifactorial. There's a genetic component, there's lifestyle, emotional, there's a lot going into it. So it's a really easy thing for me to sit up here and say, I recognize it's really hard to do. But talk with your primary care physicians if this is something you're struggling with, and see if you can work together with them to come up with a plan to help you lose some of that weight, because it really often does have a dramatic impact on your joints. Other conservative management, physical therapy. Again, tightening and strengthening things up so that joint moves nice and smoothly how it's supposed to. It's not unstable, it's not wobbly and loose. Oral medications, anti-inflammatories or COX-2 inhibitors like Celebrex, those can all be very helpful as well in moderating the pain. You might notice as we're going through there, we're not curing arthritis. This doesn't cure arthritis. In fact, we don't have a cure for arthritis besides cutting it out. So what we can do is we can do things to moderate the symptoms, slow the wear, and help the pain not be so bad. Finally, we've got a couple other things. There's injections. And these injections can be steroids, or basically that's aimed at decreasing the inflammation in the leg, as well as viscosupplementation. That's a long word that basically just means a lubricant that helps to lubricate that area. Like I said, naturally the knee and the hip are extremely smooth joints. There's very little friction in that area. Now, some of these areas, there's also some other things that are being developed. We'll talk about it at the end. You'll hear about them called PRP or stem cells. Those things are very early in development and really have not yet been shown to be very effective in curing or addressing arthritis. We'll talk about it at the end, though. Finally, for particular types of arthritis, bracing can sometimes be effective. And then there's other modalities. You can try heat, you can try ice. There's glucosamine chondroitin. Some people find that to be effective. Again, the literature is kind of uncertain on whether that has a dramatic impact. So if all those conservative treatment therapies don't work, you go through them all and you say, look, none of that helped. What's next? What can you do? And the first thing is arthroscopy. That's a little more controversial. It's basically where you put a camera in to the joint and you can try to clean down the roughness of the cartilage. It doesn't make the arthritis go away. It's just trying to smooth those surfaces. And that can be helpful for some people. Unfortunately, sometimes it also causes that arthritis to accelerate or the pain related to that arthritis to increase. For certain types of arthritis, if it's specifically in one area of the joint, particularly in the knees, you can do what's called an osteotomy, or basically cut the bone to reshape how the bone is aligned, how the joint is aligned. So the pressure goes to another area of the joint. But those are pretty limited in their scope and use. The mainstay of treatment, like I said, the only thing you can do to help that area is basically to cut out the cartilage that's left, cut out that joint surface, and put in a new surface. Typically, it's a metal surface. So I brought some toys with me today. Orthopedic surgeons love toys, and so these are some of my toys. After today, after the presentation, you're more than welcome to come up and take a look at some of these. This would be a knee replacement. And you can see that that cartilage surface is replaced with some metal and some plastic. And so basically, that's how you address the arthritis. Over 300,000 hips, over 700,000 knees are done annually. With knees, there's several different types. You can do just one side of the knee, which is often referred to as a uni, or you can do the whole knee, which is referred to as a total. And it depends on where exactly your arthritis is, which one you'd be a candidate for. In the shoulder, also there are several different types based on the problems that you have and whether some of the other problems you may have with your rotator cuff are involved on whether or not what kind of shoulder replacement you might need. But all of these have found to be very effective. And the interesting thing about the shoulder, one is called a total shoulder, the other is a reverse. And the reason for that is because they flip the ball. Usually it's a ball in the socket, and they flip it around and put the socket in the ball. So that's what the reverse is. So some common questions about are how long do they last? If I get a joint replacement, how long can I expect it to last? It really is very variable based on activity, age. The more active you are, the faster you can wear those surfaces. And then other health problems. If you have other big medical problems, that can influence the wear of your joint as well. In general speaking, though, hips and knees are very successful. In fact, they're one of the most successful operations done within surgery, and with an annual failure rate of 0.5 to 1%, so very low. In fact, most people would, if you just ask most orthopedic surgeons, they'll tell you at least 15 to 20 years for most people. And if you look at the statistics, 90 to 95% will last beyond 10 years, 80 to 85% last beyond 20. So they can have significant longevity and really dramatically improve life quality. Shoulders typically last a little bit shorter. Most people will say about 15 years. So after a joint replacement surgery, what can you expect? Well, first of all, typically, most of these are still done in the hospital. We'll talk about some exceptions to that at the end. But it's a short hospital stay, typically 1 to 3 days. You can often bear weight if it's a knee or a hip immediately after the surgery. In fact, the physical therapist will come by and get you moving right away, whether you like it or not. So we want you to get up. We want you to start moving and being active. Shoulder replacement's a little bit different. You're in a sling, and we protect it for a little longer. And then by about 6 weeks for the hip and the knee, you're usually returning back to fairly normal activity. You're still having some pain, but you're starting to be able to get up, walk around, drive, and get about. And like I said, the results are actually very good. Typically in most studies, greater than 90 to 95%. Patient satisfaction after 1 year. This study was particularly with total knees. So the results are very good. Now, I'm going to be honest with you. When we talk about this, this doesn't mean that you're getting the same knee or hip that you had when you were 18. It's not. But what it does do is allow you to go back to the activities that you want to do, walking around without significant pain, getting around, standing, getting up and down. It helps to address specifically the pain and mobility issues that may be really limiting you right now. But still, we recommend that you avoid the high-impact activities. One of the funny things I always laugh at is one of the companies has a joint replacement, a knee replacement, I think it's a knee, and you know what they call it? They call it the triathlon. No one should be doing a triathlon after they get a joint replacement. So despite the fun names they like to use, I always joke that if I ever retire from orthopedic surgery, I think I'm going to go into the naming industry, and then I get to name these fun devices. So now let's go on talking about tendons. We've talked about the joints. Let's talk about the tendons now. Remember, tendon connects muscle to bone. So what happens as we age? Well, again, you lose muscle mass. All you have to do is look at Arnold Schwarzenegger, and you know that as you get older, you lose muscle mass. He does not look like he did when he was 18. Part of that is you also have a decrease in water content. Your tendons become less resilient. They become stiffer, and so they don't tolerate stress as much, and they're slower to heal. So we often use, you'll hear a lot of words, tendinitis, tendinosis, a tendon tear, partial tear, full thickness tear, all these things. They can become really confusing. I'm going to hit the big ones today. Tendinitis. Itis, who remembers what itis means? Ouch. Inflammation, right. So tendon inflammation, that's all it is a tendinitis is when that tendon, that area, the tissue that connects the muscle to the bone gets irritated. And typically it happens because you've either increased your activity too fast, you get this, I'm going to go from 0 to 60, and your body doesn't like that. It likes gradual increase because it's not, that tendon isn't used to seeing that high level of stress so quickly. Or it can happen from trauma. You do something too fast in one moment and can really injure that tendon and inflame it. Or you can do it from just constant overuse and repetitive action, never giving that tendon a chance to heal and to rest. Our bodies need rest. I tell this, like I said, I do a lot of sports stuff too. I tell this to young athletes all the time too. Your body has to have time to rest. No matter if you're young or you're old, it needs time to recuperate. So if you don't, there's a good chance you're going to find yourself with an area that hurts and you have some tendinitis. Common locations: thumb, elbow, shoulder. It sounds like the song, right? Hands, shoulders, knees, and toes. That's kind of what it is. So what do we do for it? Well, luckily with tendinitis, it's pretty rare that we have to go to the operating room for this. It's very uncommon. The conservative management is really very effective. Again, it's activity modification, taking a rest, getting off it, giving it a chance to heal. Physical therapy helping to stretch it out, stretch that area, because often that muscle is just too tight, and so that tendon is always under tension. And so you give it a chance to rest and relax because by stretching. Anti-inflammatories, bracing, and injections can also be helpful. So a tendon tear then, if that's just inflammation, a tendon tear is when you actually rip it. You tear that tissue and it's no longer intact or only partly intact. So if it's partly intact, there's some of that fiber. So if that tear, instead of going all the way through here, if this side were still touching and still in connection, then it would be called a partial thickness tear. And you often see that. The most common locations for tears are in the rotator cuff, quadriceps, Achilles, biceps. So rotator cuff is shoulder, quadricep is right above the kneecap, Achilles is on your heel here, and biceps, we all know what that is. And so often some of those will require surgery, but often we can still try treating them non-operatively first. Rotator cuff tendons, this is something that a lot of people, I spend a lot of my time working with people with rotator cuff tendon tears because they are very common, particularly as we get older. So you hear it all the time, oh, I've got a rotator cuff tear. What does that mean? Well, there's a group of 4 muscles that help to stabilize the shoulder joint, and they come across that shoulder joint and they attach onto the humeral head. And almost 2 million people in the U.S. every year have problems with their rotator cuff. And you can have 2 types well, you can have tendinitis in your rotator cuff, first of all. So this area can get inflamed, but if it gets inflamed and it becomes a big enough problem, then you can have a tear. And that tear can be partial thickness, meaning only part of it's torn, or it can be a full thickness, like this one, where you can actually, it completely tears and you can look down and see the bone where you shouldn't be seeing the bone. So the causes for that, it can be an acute trauma or injury, basically you fall or catch yourself or your shoulder gets torn back, that can cause that tear, or it can be degeneration, basically just wear and tear of normal daily life. You've been active, you've been doing things your whole life. The interesting thing is that it isn't always painful. Not every rotator cuff hurts. And several studies have shown this. There's a prevalence as we get older, it becomes far more common. In one study, they estimated that perhaps over half of people above the age of 65 have rotator cuff tears. Most of them don't even know about it. Another study showed, in another specific study, it showed that 17% of people who had no shoulder pain at all, and this was just in the general population, they took a bunch of people in the general population and said, hey, we'll give you a free MRI of your shoulder, come on in. And they got a free MRI, and almost 20% of those people had a rotator cuff tear. They didn't even know it. Didn't hurt them. So not every rotator cuff is painful. But what are the symptoms? So how do you know if you have a painful rotator cuff? I love this poster here. Not all pain is gain. And this is a classic case here. Pain at rest, pain at night. If you're laying on that shoulder and it just kills you. Pain when you're lifting or lowering your arm. Weakness in that arm, you find, hey, I can't even lift my drink to my mouth anymore. Crepitus or crackling, feeling like a grinding in your shoulder. All those things are suggest that you may have a rotator cuff tear. It could also be, in some of these, may be a sign of just tendinitis, but it says that something's going on with your rotator cuff. So how do we know if we have a rotator cuff tear that's bothering you? First of all, I now know I've probably scared at least a half of you here going, oh man, do I have a rotator cuff tear? I got to go sign up for an MRI because I want to know. If it doesn't bother you, don't fix it. Again, you don't have to fix them. We just treat the painful ones. We don't have to treat the non-painful ones. If it doesn't hurt you, don't worry about it. You can forget about it. So if it is bothering you, you are having those symptoms we just talked about, first thing we do is do a physical exam. We look at you. There's some tests we can do to see, hey, is it likely a rotator cuff tear or is it likely something else? Then if we need to, we can go on and get further imaging. We always start with x-rays, look for things there, and then we can get an MRI. MRI or ultrasound, both are great modalities for us to see if you have a rotator cuff tear and how bad that rotator cuff tear might be, and whether or not it's something that we need to be more or less aggressive with treatment. Even then, treatment for the rotator cuff can often start with conservative management, particularly in the degenerative types of tears. Start with activity modification again. Not using your arm quite so much, not trying to do the heavy lifting or constantly lifting or raising that arm, but modifying that, and that in conjunction with physical therapy. Again, helping to strengthen those muscles, help to calm down the inflammation. Anti-inflammatory medications and injections can also be somewhat helpful. One of the interesting things is, if you go onto the American Academy of Orthopedic Surgery's website, if you have a chance, I'd highly recommend going to that website. It has a lot of great information, particularly about the rotator cuff tear. It quotes a study there that about 50% of people who are treated non-surgically for a rotator cuff tear get better. So, and those are particularly with degenerative types of tears. So if you don't have a specific injury when it all started, we want to start conservative. There's no reason to rush into the operating room because, half of you aren't going to need it. Half of you will get better all on your own. And if we can avoid seeing me in scrubs and a mask, it's probably a good idea. I don't look that good in scrubs, trust me. So, if we do, though, if we go through all those treatments and you don't get any better, surgery is an option. And it's typically done arthroscopically nowadays. There's very few people around the country that open it up anymore, just because who needs a big incision when you can get one this big and do it just as well. And so we can do either an arthroscopic repair, or debridement basically means cleaning it up, depending on how bad the tear is. The majority of patients report improved strength, less pain after surgery. So they get their motion, they get their strength back, and the pain is gone. It can be a very effective surgery. Recovery for surgery usually takes 4 to 6 weeks in a sling. You return to full activity in about 3 to 6 months. So now let's talk about bone. So we've talked about joints and arthritis. We've talked about tendons, tendinitis, tears, bone. We talked about bone as a living organism, right? Well, bone grows. It basically, within here, you've got this woven trabecula, and that basically dissolves and then reforms, and dissolves or resorbs and remodels. It's amazing. But what happens as we get older is the mineral content of the bone decreases. That trabecula gets thinner and thinner. As you can see here, the difference between this side and this side, the honeycomb gets bigger. That's not good. It means that the bone is more brittle, and because it's less dense and becomes more fragile. And this is often what we call osteopenia, and then on to osteoporosis. I'm not going to talk too much about osteoporosis today. That's something that's a great talk that you can have with your primary care physician if there's a concern for it. But really, as our bone gets older, we increase the risk for fracture or breaking of that bone. So sometimes when I had first started as an orthopedic surgeon, I can still remember I was down in Memphis, and I came in to talk to a person. He had a horribly broken leg. It was one of those that he knew it was broken. It was in 2 different zip codes. And I walk in and I said, I'm sorry. Unfortunately, we got the X-rays back, and as you probably suspected, you have a fracture of your femur. And he looks at me and he goes, "Oh, that is such good news, Doc. I'm so glad to hear that. I thought it was broken." It's just fractured? Good. Again, same word or same thing, just 2 different words. Fracture is a break. So, yes. Common locations. Hip fractures. Hip fractures are extremely common as we get older. In 2010, there were over 250,000 hospital admissions for hip fractures in people above the age of 65. And they can have a huge impact on life. There are other common areas: the shoulder, the wrist, the ankle. You'll kind of see a common theme here. Falling. Falling has a big impact on this. And as we fall, it's the areas that we hit as we get older. That bone just can't withstand the stress anymore. And now, the spine. You'll find orthopedic surgeons stand on 2 sides of a fence. We either like spine or we don't like spine. There's orthopedic spine surgeons over here that like spine. Everybody else over here. But that's just, no, I don't do a lot of spine, but spine is also a common area. And again, their fractures are a little different. Spine fractures are compression fractures often, where they just smash together because they don't have the strength they used to. So, when we're talking about treatment, there's a handful of these fractures that can sometimes be treated with non-operative or conservative management with bracing. Those are more often in the upper extremities, the shoulder, the proximal humerus as we call it, or the wrist. Some of those can be treated, but even not all of those. So often we will have to do something called plating. You'll have heard of plates. Now, when I first thought of it, I couldn't really imagine what a plate, I can still remember when I was starting medical school and they talked about plating things. Well, plates are just little metal bars that can be put on, and they put in a bunch of screws that can hold the bones back together. So we can plate things. In the hip, we often use a handful of different things. You can just put some screws up in there. You can put a big screw and a bar, or a big screw and a rod. If you ever hear about nailing, someone says, "Oh, I got my femur nailed." Well, this right here is a femur that got nailed. It's a big, long metal tube that goes through the middle of the bone. The bone has a hollow canal there, and it goes down that canal. Or you can basically get a partial replacement or a total replacement of the hip, depending on the fracture. Now, some people ask, how do you decide which? It really is dependent on the fracture that you have. Certain fractures need one thing, certain need another. And it's depending on where, here on the neck, this area that sees a lot of stress, where that fracture happens and how badly it happens that determines what you'll get. In terms of recovery, hip fractures, treatment of hip fractures particularly can be very successful in terms of getting the bone to heal and getting things back. But because these fractures are often signs of other things going on, signs of that aging process, often it can have a huge impact on ability and mobility. So usually once these procedures are done, you can often put your full weight on it. You can walk on it right away, and you can start getting around on it right away. However, if you look at long-term, if you look at the literature, the research, you can see up to 90% of those people who were able to climb stairs now no longer can climb stairs. 66% of people who weren't able to get up off of the toilet or get up from a deep-seated position no longer can. And when you look at this, it looks, when I look at this, it looks pretty daunting. I can tell you anecdotally from my own experience, it's probably not quite this high, but I think the take-home message is real, and that is that it does have a big impact on function. When you break your hip, it can dramatically impact what you're able to do. And so trying to prevent falls, exercising, keeping your body strong, taking the vitamins that you need are all things that you can do to help limit that happening. Because while we do a great job of fixing the bone and making the bone heal again, it can really have a dramatic impact on your life. Similar with the proximal humerus fracture or the shoulder fracture that we were talking about, while yes, the bone, we can get that to heal really well, it can take up to a year to really get back to the healing process and start feeling and being able to use that shoulder like it's normal again. So, to finish off, what's the future? What are we looking at? If we got into our DeLorean, took off, and in fact, I don't know if you guys ever watched Back to the Future, but when in Back to the Future 2, they go into the future, and who knows what year they went to? 2015. October 21st. I'm waiting for my hoverboard. So what does the future have? Well, first of all, there's some conservative treatment therapies that we're working on. Right now, I'm going to be honest, the research hasn't borne them out to be fruitful. They're not something, they're usually very expensive right now, but they haven't shown to be effective in a large number of good studies. That's plasma-rich protein, stem cell injections. Those things, like I said, they can be expensive. And really, the study hasn't shown how they're best used, whether they're even effective, but hopefully we'll find something. And currently, they're not recommended by the American Academy of Orthopedic Surgeons. Other new innovations in terms of the metal and the plastic, as we talk about things, there are companies that are coming out that are working on the surfaces of the joints that they're putting in, the plastic that's in the joint, helping it to last longer. And in fact, one company has come out and said that they believe that their joint, the testing they've done on their implants, can help those last 30 years or more. And several other companies have followed suit. Yet to be seen for sure because they haven't been around for 30 years. But it's hopeful in that we can provide surfaces that will last even longer. And because if they can last longer, we don't have to do anything more to replace that joint that's already been replaced. Finally, there's better management of post-operative pain. Joint replacement is in some places is starting to be done in an outpatient setting. I think in the right patient that can be done. You've got to be careful here because pain is a big issue after surgery, and the last thing you want to do is just find yourself at home early, which is great, but in a lot of pain where you don't have appropriate pain management. So as we work on improving pain management, making sure that we've got the help and provide often if you've got a lot of other medical problems going on, doing it on an outpatient setting may not be the best idea, but as we perfect that model and as we help to develop protocols and means of managing pain, it can be a real potential in the future, and it's already in the process. So, there's the big cliffhanger. Woo! Glad you guys stuck with me to the end. I know the whole reason was just so you could see this picture. That's my beautiful wife, Valerie. This is my 8-year-old son, Noah. My 6-year-old Eli, yep, he lost his front 2 teeth. Bottom first, not the top. I don't know why. And then Emma, she's my 4-year-old. She's a darling. And the baby of the family is Haley, who is just full of spunk. So there's my email. If you have any questions, feel free to drop me a line on email. Those are my 2 phone numbers. The first one is just the general office number for us. The second one is actually my assistant's number, Deb. You know, if you're lonely and need someone to talk to, Deb is a shoulder to cry on. No, but if you have any serious questions or need an appointment or want to talk, you can call either of those numbers and we can get you an appointment. But ultimately, I think as we go through this, aging is a great process. It's something that the medical advancements have made it far easier than in the past, and certainly there are a lot of solutions for the problems that exist. So like I said, any questions? Let's go to those. Start in the front here. That's a great question. So her question was, if you've already had a replacement, you've had a joint replacement like 15 years ago, how do you know if you need a new one? That's a great question. Usually it starts with pain and swelling, and then go see your doctor, because they'll probably want to get some x-rays and look at that, because they can look at the spacing, particularly if it's a knee, look at the spacing of the plastic in there, similar to the hip. They'll look and see if the plastic is worn out. That's a great question. What's that? Yes, so that's exactly right. So what can happen is what we call a revision, or basically doing it again. They'll have to take all the metal surfaces typically out. Every once in a while you can just replace the plastic, but often you have to take all the metal surfaces back out and put in new metal surfaces. And typically a revision is not as good as the first one. If you look at the research, it's just not quite as good. It still has good results, does great, but just doesn't last quite as long, and often can have a little more pain associated with it. Yeah, that's a great question. In fact, I have probably at least once a week, some friend or family member will ask me that exact question. What about this? What about this new? That's a great question. There's a lot of things on the market, and I'll tell you, this is kind of my standard answer. There's a lot of things on the market. I can't tell you for sure whether it works or not, mostly because they can't tell you for sure whether it works or not. They haven't done the studies. What I would say is I recommend things that the research bears out that can have consistent results and consistent positive results, and also as I use those modalities and verify that what the research is what I'm seeing as well. So unfortunately, as we saw, arthritis is a huge problem in the country. It's something that a lot of people suffer with, and so it's low-hanging fruit for a lot of companies to make something to try to fix. Again, I can't. Most of those I can't say whether or not they work, and most of them don't have great research for them to say whether or not they work. They may. Yeah, and the one thing I would say in addition to all those, if you want to try some of those, I'm not opposed to them. I would say talk to your primary care doctor, the person who's looking at all your medications, because the one thing you don't want it to do is exactly what you said, and that is to hurt you. You don't want its effect to have some effect with the other medications you're taking and cause other problems. But from my personal position, if it doesn't hurt, if it doesn't interact with any of your other medications and you want to try it, I'm usually not opposed. I say, hey, try the conservative management things first. If it helps you, great. One kind of a side note to that, sometimes you'll hear the word placebo used around, and a lot of times it's almost derogatory. People say, oh, that's just the placebo effect. Well, hey, if somebody told me I could take a Skittles and it would make my pain go away, I don't care. Skittles are a lot cheaper than a lot of these other drugs. So don't be, whether it's placebo or not, if it makes you feel better, go ahead and keep, it's not causing any problems. You've talked to your primary care doctor and you feel like it's helping you. My personal philosophy, keep going. Keep going until it doesn't work. So yeah, trigger finger. I'm going to be honest with you. I've got a couple of really great partners who manage hands. I stay away from them.
Is that cartilage in the trigger finger?
It is typically not. What a trigger finger is some area around the tendon slips, or basically where the tendon slides through, gets inflamed and thickened. And so what happens is it catches, and that tendon can no longer slide back and forth. Our bodies are amazing. There are a bunch of pulleys, and as there's contraction, you get that joint to move, and that's really what it is the pulley now has a big lump on it, and it can't slide through. And so that's what a trigger finger is, and there's a lot of great things to treat it with, and not always surgery. You can usually start conservative as well. let's go here and then there. Great question. Are there foods that we can eat or not eat, was the question. You know, again, there's not excellent research. Calcium and vitamin D are two things that are very helpful. So getting your calcium and getting your vitamin D, that's great for bone health. But specific foods, I can't quote you and say, hey, everybody eat 15 bananas today. Yeah. Great question. So why is it that weather causes joint pain? They think it likely has to do with the barometric pressure, actually. It's the changes in pressure causing changes in the knees. It's actually, even when if you have any joint replacements, and that's one of the things, often with joint replacements, or if you have any metal in you, some people have a little soreness with the weather change still, and that often probably has to do with the barometric pressure changing, causing that difference and causing pain. Yeah. The question is can you just shave off the spur, and will that make the pain go away? Typically, that's not the case. It would be very, very uncommon. The spur is typically a sign, not a cause of the pain. So, for example, it's showing you that the cartilage is thin there. So if you go off and shave that spur down, but the cartilage is still thin, that bone there is still getting annoyed, what's going to happen? It's going to come right back. And that's typically what happens is if you went in and just tried to shave it down. Now, what you can see sometimes is actually they may go in and shave the cartilage around there, because if there's a cartilage area that's flapped, kind of like an orange peel that's only been partially peeled off, but it's still on the orange, and every time you kind of run your hand over the orange, it would catch that peel. In those cases, similar to that, the cartilage can do that. It can start to peel. You can shave the cartilage so that it doesn't catch. And but you don't, just shaving down the bone spur typically doesn't relieve pain. Yeah, a PCL tear. Great question. So the PCL is, everybody hears about the ACL. The ACL is the one in the front. It's called the ACL because it's the anterior, meaning front, cruciate ligament. Its sister ligament is the one behind it. It's the posterior cruciate. They cross, just like this in the knee. So it sits, oh, there goes my bottom. They sit in the back. And in fact, this is the PCL. So in terms of success rates, typically it depends on, that's a pretty complex question because there are different types of tears, how severely it's torn. It can be very successful. Usually they don't have to be fixed, to be honest, if in isolation. Often they will heal on their own. It's one of the few ligaments in the knee that we can say, hey, just leave it alone, and it typically does better. If it does need to be reconstructed, usually you can have very good results with that. I can tell you that, yeah, the results I've had are usually very strong. Arthritic knees, and the question is can I talk about arthritic knees and Baker's cysts? Yes. So Baker's cyst is basically a pouching in the back of, full of fluid in the back, typically in the back of the knee. And those can often occur when you have arthritis. What you can think about is around the knee, there's what we call the capsule. You can think of it as a balloon that covers the knee. And what that capsule's job is to keep the fluid that lubricates that knee around the knee, so it doesn't go all the way up the thigh and where it doesn't need to be. So it helps to keep things in there and keep it tight. Well, if you've ever played with one of those balloons that the clowns use to make the different animals, and if you squeeze one area, it pops out another part. Well, similarly on that capsule, if you squeeze that capsule, or basically compress that capsule, and compress it, that particularly as we bend, that capsule can get squeezed, gets compressed, and so that fluid under tension has to have a place to go. And so it finds the area that is weakest in that capsule, which typically is right in the back here in a particular area, and it pooches out, whoop, just like on those balloons. And so again, typically a Baker's cyst is not the cause of pain. In most cases, they're painless, but they're a sign that your body is often producing more of that fluid than it needs to, and that's because there's irritation. Your body produces that lubricant, that fluid, because it says there's something wrong going on. I got to make it smoother. I got to make it smoother. So as that fluid gets stimulated to form, you get more fluid in the knee, and then it can form that little pouch there.